Good afternoon, everyone, and welcome to the Innovation Network for Health and Care Wales. Can I just ask everyone to mute themselves, please, just so it stops any background noise and means that we're not all kind of cutting over each other. I'm just going to leave a couple of minutes for everyone to kind of join. I think there'll be a kind of slow process of everyone getting into the call. But like I said, nice to see everyone, some familiar faces, some new ones. My name's Jonathan Morgan, so I'm a Valley-based healthcare project lead at Life Sciences Hub Wales, and I'll be chairing today's meeting. And as you can see up on the screen, this is the Innovation Network is hosted by Life Sciences Hub Wales, but it is an attempt to bring everyone together from across Wales with an interest in innovation, and that is healthcare, industry, academia, third sector, really around trying to kind of drive innovation across our health and care system. Today's a really exciting session for us because it's going to be the first in a series of what are themed meetings. And today's meeting being the first of those, being our prevention themed meeting. And we've got a really exciting agenda today, and with some really good presentations coming up. Like I said, I'm going to leave it a little bit longer just for everyone to kind of get a chance to come in. We've got quite a good few number of sign-ups today, so I just want to give everyone the chance to kind of start right from the beginning with us. For any of you that are new to the Innovation Network, thanks for joining us and welcome. Feel free to use the chat to introduce yourself if you're new to the group. If you want to ask any questions, the chat is there to be used in that way. Like I said, we'll be running through the agenda, and it's quite a packed agenda today with a number of presentations from a number of individuals. And there will be opportunities to ask questions across the meeting. So that chance will come at the end of each of the presentations. But again, if there's some kind of wider questions that are more innovation based, please feel free to put them into the chat, because likely thing will be there'll be someone in the meeting that may be able to help or may be able to answer that question for you if it's not myself. But like I said, Pranawdar everyone, and good afternoon, and welcome to the Innovation Network for Health and Social Care in Wales. Like I said earlier, really excited to kind of start off our series of themed meetings with prevention today. And Priya, if you can put back up the agenda for me, that would be fun.
Yes, yeah.
And like I said earlier, if I can ask everyone just to mute themselves, as in it just means we won't have any kind of background noise going on for the session. So I think we'll get started, and people can join as we kind of come on. The luxury of being on an online kind of meeting. And like I said, really exciting agenda today, and we're going to have an introduction from Mark Griffiths from Public Health Wales, who's just going to kind of give us a nice intro into what is our prevention theme meeting. And then we've got about I got muted then, apologies everyone. From a range of different people from across health and care and industry. So we're really trying to make this, give that kind of perspective from all different parts of the health and care system, whether that be, health themselves, care themselves, or also our industry partners and our academic partners as well. So I think we've got people will start to come in now. So I think we'll get started just to avoid kind of any, running over and taking up everyone's time towards the end of the session. So, like I said, Pranawdar everyone, welcome to the Innovation Network for Health and Social Care in Wales. My name is Jonathan Morgan. I'm a Valley-based healthcare project lead in Life Sciences Hub Wales, and Life Sciences Hub Wales hosts the Innovation Network on behalf of Wales. And like I said, today is the start of our series of themed meetings, and today is the first, which is prevention. We are going to be working through those bit by bit as we go through the session. And like I said, there will be opportunities to ask questions towards the end of each presentation. What I will ask is that if you do want to ask a question, just put your hand up and we'll come to you. We'll try and fit in as many as we can. If you don't want to ask the question yourself, fine, put it in the chat and I'm happy to do that for you. But, with this being a network, we do encourage people to kind of, say hello and kind of ask some questions. When you do ask a question, please feel free to introduce yourself, where you're from, what you do, and that just helps for the network so we can all get to know each other and understand, where we can ask for help in the future. And yeah, I'm going to start now, so I think we'll get cracking. And up first, we've got Mark Griffiths. So Mark, I can see you're in the top right-hand corner of my screen. So welcome. And Mark is from Public Health Wales, and he's going to kind of give us that intro into the prevention theme. So Mark is the Research, Innovation and Improvement Coordination Hub lead and Programme lead for Innovation at Public Health Wales. And I asked Mark to come along to just kind of give us that kind of starting point for the meeting so that we can really get a good idea of where we're going through from a prevention point of view. So over to you, Mark.
Thank you very much, Jonathan, for that introduction. I'm just hoping to share my screen now so everybody can see my slides. I've got a few slides just to begin proceedings. And as Jonathan has already mentioned, I am the Research, Innovation and Improvement Coordination Hub lead for Public Health Wales. And if you don't know what the RIC hubs are, then I'll say a few words about that in a moment, and also improvement lead within Improvement Cymru. And if you don't know, Improvement Cymru is the National Patient Safety and Quality Improvement Directorate within Public Health Wales. So if you were to look on the internet, a quick search on Google would show that there are many publications which talk about innovations to prevent ill health and promote good health. And certainly recently there's been greater attention towards innovation and prevention following, of course, the COVID-19 pandemic. There's lots of information around infection prevention and control and service restoration. And of course, this is all with the aim of supporting population health and well-being, as there's been lots of delays in services and hospital treatments and increases in mental health pressures upon the young and the old alike. And a lot of prevention is around dealing with some of the wider social determinants, which often occur outside of the traditional boundaries of healthcare. And of course, with a focus upon improving quality and efficiency and reducing waste. So how can innovation and innovation aimed at prevention support some of these activities? So I'm sure you don't need any reminders about the Welsh policy context, but in case you do, then back in 2018, the parliamentary review was published, which suggested that health and social care was unsustainable and that radical transformation to the delivery of services was needed. Welsh Government's response, of course, was the publication of A Healthier Wales, which talked about the transfer of services over a 10-year period away from primary and secondary care-based care and treatment, more towards the well-being and prevention agenda, with care closer to home and within the community. And one of the actions within the Healthy Wales Action Plan was the creation of these RIC, Research, Innovation and Improvement Coordination Hubs, which were created across the regional partnership boards, with also support from the 3 existing trusts of Public Health Wales, Welsh Ambulance and Velindre Cancer Care. And of course, more recently, Welsh Government has consolidated through announced as a written statement the consolidation of existing health and social care innovation activities into a single programme of work. So we're all keenly looking forward to see and hear what that has to say about innovation going forward. So a few perhaps examples that you may or may not be familiar with. Of course, there are many challenges from an ageing population in Wales, perhaps more so than in other of the UK nations. And about this time last year, in the Institute of Welsh Affairs, an article was published which was talking about delivering integrated health and social care partnership between a GP practice and a home care provider organisation, in which community social care staff were trained to do basic observations with the patient in their home. And this was supported through video consultation with the GP as required to assess the best course of action for the individual in their home. I suppose a question that could be asked, maybe of ourselves, is does this model have a future for integrating health and social care? And if it does, what is the tipping point to sustain scale and spread of this type of activity? Other examples, being led by Cwmtaf Morgannwg Health Board with support from other partners, is innovation through gamification and incentivization. So if you just look on this website, getfit.wales, you'd find more information about how there's a schools-based program to support physical well-being and promote healthy development through an innovative use of Fitbits to, as we say, gamify and incentivize younger people to remain fitter and healthier. Other examples, perhaps, back up in North Wales, mental health and well-being. This isn't something new, but back in 2019, they announced a shift in their focus away from mental health care towards a prevention and early intervention agenda. Other examples, focusing particularly upon COVID and infection prevention and control, examples of door closures and door openers in Prince Charles Hospital. So some relatively simple innovations and ideas that have popped up locally, and I'm sure you know of others. You could speak about those yourselves. And these are not massively disruptive, but of course, when people think about innovation, they often think about some of the more digitally based and electronically focused innovations around telehealth or AI, and how these activities can support health and social care, augmented reality, virtual reality, mixed reality, how this supports training and, of course, helping others with particular conditions, and robotics. And I think looking at the agenda, some of the talk themes around aging, mental health and well-being, such as anxiety and social isolation, are reflecting upon how technologies are helping in these areas. I think there are some talks around AI and electronic platforms for respiratory care. And many of these concepts are coming together to support, for example, elderly with issues of loneliness and those at risk of falls. The use of technology to keep people connected and as a fail-safe mechanism if something was to go wrong within their own homes, so keeping them as well for as long as possible in their own familiar environments. But this does raise questions around the digital divide and reducing that divide for elderly ones. And perhaps if COVID has shown us one thing, it is that the elderly population aren't as digitally disconnected as many may have thought previously. So just bringing all of that together and reflecting also upon the activities of the RIC hubs. So rising up like a phoenix from the flames of the RIC hub partnership, not to say that the RIC hub network is in ashes necessarily, but the three trusts, Public Health Wales, Welsh Ambulance and Velindre Cancer Centre, are looking to the future to build upon the existing work of the RIC hubs that we've been doing around these 6 key core principal themes around population health, so primary care, integrated care and well-being, digital solutions, informatics, including big data, cancer care, which is something that all the 3 trusts have an interest in, diagnostics and point of care testing at home or close to home, and logistics, so the delivery of healthcare, for example, through the use of drones or other mechanisms. And there are perhaps other themes that will be added to this matrix over the course of time. So hopefully we'll be able to share more information about that over the course of time. And we're looking, of course, to collaborate more closely with others on that innovation and prevention agenda in the future. So watch this space closely. So I think hopefully that will set the scene for today's meeting. Jonathan, thank you for the opportunity to present some slides on that, and I'll hand back over to you now.
Thanks, Mark, and absolutely, I think that's kind of really set the tone for the meeting and given us some of that kind of policy background as to why prevention is so important. And I think you give some really good examples there about where innovation over the past 18 months has played its part in preventing some of those changes, especially like infection control, and why it's so important. And we are really talking about behaviour change when it comes to prevention. How can we change the behaviours of those who we're dealing with for the better and to result in better health and better outcomes for the population. So yeah, thank you very much, Mark, and really exciting to hear what the RIC hubs have in the pipeline coming through. So yeah, maybe you can come back and tell us how that progresses over the next 12 months or so. So thank you very much to Mark and for giving us that kind of introduction and kind of tone setting set of slides. And I'm going to move on to our first presentation and our first presenter. So starting us off for the meeting, we've got the presentation on Better Together, Getting Back Out There, and that is going to be delivered by Andrea Nicholas-Jones, who's the Director of Strategic Partnerships and Policy for Elders. So Andrea, if you're there.
Yes, I am, but I don't have the button to request control to be able to put my slides up.
Okay.
It was there a moment ago and now it's gone.
Okay. Let's, Priya, are you able to?
Nope.
Andrea, would you like me to share your slides for you, and if you just request to move on to the next slide, please? Yeah?
Yeah, that's fine.
Absolutely no problem. One moment.
Thanks, Priya. So over to you, Andrea.
Great. Okay then, so as has just been introduced, my name's Andrea Nicholas-Jones and I work for a charity called Action for Elders. Can I have the next slide, please? And a new initiative that we've started as a response to COVID has been an initiative which we call Better Together, Getting Back Out There. Next slide, please. I think one of the key things that we've learned from COVID is that older people have been disproportionately disadvantaged by the initial shielding policies, and that has had a massive contribution to the incidence of loneliness and isolation. And I think we all are aware of the health risks that are attached to loneliness and isolation, particularly for older people. It's likened to the effects of smoking 20 cigarettes a day. So it's a real significant issue, and I think one that COVID has really polarised for us. Next slide, please. And it's not just the fact that loneliness and isolation causes potential mental health issues for older people, but it actually does cause physical conditions that in the body, which leads older people to become more vulnerable and more likely to need to access services. Next slide, please. And these are just some statistics that have been gathered around what incidents of loneliness and isolation that we've had. Interestingly, you'll note that in Wales, there's a higher proportion of 16 to 24-year-olds saying that they were lonely, as opposed to people aged 75 or over. I'm quite cynical about this. I think, again, it's an expression that we use quite often, but people over the age of 75 now, the post-war generation, are pretty much the put up and shut up generation. So they are less likely than younger groups in the population to actually report anything negative about their lives. So I would suggest that actually that 10% age 75 or over is a massive underreporting of how older people have experienced loneliness and isolation over the last 2 years. And I think it's also important at this point to distinguish between loneliness and isolation. So I like to quote my mother-in-law in this. So my mother-in-law had 5 children, all of whom had partners, had 17 grandchildren and 34 grandchildren, all of whom rallied around her when my father-in-law died. But 5 years later, she was basically lonely and she felt isolated, because even though she was surrounded by children and grandchildren, all of her friends had gone, her life partner had gone, and she just felt that there was nobody that she could relate to. So she was certainly not isolated, but she was very lonely, and that had a significant impact on her quality of life for her remaining years. Next slide, please. The people that we worked with on our previous programme, Balanced Lives, when we went into lockdown, they were expressing incredible concerns about what that was going to have as an impact on their lives. They were used to going out, they were used to having social connections, they were participating not just in our programme, but they'd visit friends, they'd go for coffee, they'd basically had a life. And as soon as they were put into a position where they were shielding, they really found that it had a massive impact on them very quickly, both in terms of loneliness and isolation, their mood and physical activity levels, to the point that about 6 weeks into isolation, and shielding, one of our respondents was actually questioning whether their life would continue to be worth living, if this is what was going to be their future. They couldn't see an end to when shielding would end, and they couldn't actually see how their lives would recover if there was going to be any substantial period of shielding for them. Next slide, please. So what we did was we got together with the older people that we'd been working with whom we had a relationship. I mean, just before we went into lockdown, we were working with about 2,500 older people across Wales, and we talked to them about what would make lockdown, however long it was going to last, manageable and survivable for them. So we very much developed the programme based on what they told us. And the first reaction that we had was we would need to put things online because we had to make sure that people could stay connected. We'd already put a telephone service in place, so we were ringing our group participants a couple of times a week. We had staff who, instead of running classes, were dropping off prescriptions and shopping until people were able to put more robust and sustainable solutions in place. But people were saying even with telephone contact, they missed seeing other people, they missed that face-to-face contact. So working with our older people, we started to move all of our provision online. So we set up Zoom sessions for our classes, so people could actually not just engage with a tutor, but they could engage with the people that they'd previously been in physical classes with through virtual Zoom rooms, where they could be participating in exercise. We set up a jigsaw club, we had a book club, we were doing arts and crafts, we were doing all sorts of different activities, but using Zoom as our platform. And that was great for a few of the older people that we were supporting. However, there were also a significant number of older people we were supporting who wouldn't or didn't use technology. And some of them didn't have access to either the technology that they'd need to join in with Zoom or actual internet access, which is something I'm sure we all find bewildering. But there are a significant number of older people out there who didn't even have Wi-Fi. So at quite significant expense, we went out and bought tablets and we bought dongles, and we distributed those to the older people that we've been working with who didn't have access to technology themselves. We employed a full-time IT support person. We didn't call them a tutor because what we didn't want to do was start running IT courses, because nobody wanted to do an IT course. They just wanted to be able to get onto our Zoom classes. They wanted to be able to FaceTime their friends and relatives. And the friends that they built up during participation in our programmes. So Aid became the man that would ring people up and talk them through what they needed to do to get online, or who would remotely access their equipment and get them online. And whenever we did a class or whenever people were doing any of the sessions that we were putting on, Aid would hover in the background and was there to troubleshoot if people lost their signal or had any particular issues. So we really wanted to make sure we sustained all those principles which our physical classes were based around, which was sustaining the mental, social and physical well-being of older people, supporting them, enabling to stay in the community safe, well, independent as they could be, with good relationships, and also the opportunity to make new relationships. Next slide, please. So these are some of the activities that we started and were running during the COVID crisis for older people. So we ran mindfulness sessions because people were saying that they were just finding that their anxiety levels were just increasing at an exponential rate. And even though they were accessing our traditional courses, they just wanted more coping mechanisms for dealing with the loneliness and isolation they faced. So we set up mindfulness sessions. Instead of our face-to-face tea and coffee mornings, we were running virtual sessions. We started running cookery classes where people would be cooking along with the tutor, and then everybody would sit and eat their meal on Zoom. It might sound a bit bizarre, but actually for people who are lonely and isolated, any activity where they could see other people was really meaningful. What we then started moving on to, as we started to come out of lockdown, earlier this year, we started putting on safe, structured activities to try and encourage older people to get back out into the community again, whilst not forgetting the people that we needed to support who were in their own homes. So we have started doing some social gatherings, which are safe. We're running them in community venues around Wales, and we're encouraging people to get together and just sort of break down that barrier that so many of our participants have said that they think is preventing them from actually getting back out into the community again. So they haven't started going back to the pub, they haven't started going back to Tesco's to do their shopping, because they are still very fearful of what that social interaction could mean to them in terms of the risk that there still is around contracting COVID. So we're setting up safe settings in which people can start getting together again, and hopefully to start bridging that gap and getting them back out into their community and to be able to participate in meaningful activities, whilst all the time keeping all of our online provision available, again as a way of reinforcing what older people will need to be doing to stay healthy and well in their own homes, to enable them then to get back into the community. Next slide, please. So these are the outcomes that we set for our Better Together Getting Back Out There programme, and I won't read through them all, but we're really just trying to evaluate the interventions that we've done robustly, so that we have a model that not only will have had the qualitative feedback from older people in terms of how our programmes have made them feel, but we'll actually have some quantitative evidence as well, and evidence that can be measured against recognised scales, to actually have something, a robust evaluation of the programme, and hopefully something we can build on in the future as we take our development forward. So we've got criteria that we set against community inclusion. And the next slide, please. We're then looking at how we can support individuals, families and communities to lead that active and meaningful life. And again, we're looking at independently developed evaluation criteria, so we will have something to benchmark against in terms of our provision. And the next slide, please. And then finally, and the most critical one, I think, if everything else is going to be effective, is we will be looking at improving mental well-being and the ability of the people participating in the programme to both build and sustain positive relationships. And again, we'll be using the Warwick Edinburgh Mental Wellbeing Scale to measure that. Next slide, please. In addition, we've done a lot of work on evaluating our community-based programmes over the last 5 years. And these are some of the findings that we've got from our evaluation, which has included independent evaluation. It's not just ourselves patting ourselves on the back and saying what a good job that we do. So we estimate for every £1 invested in our programmes, we're saving statutory services approximately £5. And the main purpose around our programme is keeping people well, both physically and mentally. So our participants have less falls, they have less GP visits, we see reductions in the amount of prescribed medication that they're taking, and we're seeing people having increased interaction and increased independence, whatever setting they live in. And one of my favourite stories is of an older gentleman that we had living in a care home who was a two-handed lift before he started doing our programme. And after a year, and okay, a year is a long time, he was able to go from sitting to standing independently, because we'd managed to develop his core strength, his upper body strength, and strengthen his legs from doing wheelchair-based activities, but we enabled that individual to be able to stand independently, and that was a massive boost to his self-confidence and had a massive overall impact on his well-being and also on the individuals who are providing care for him. Next slide, please. So this is something we all know, and I make no apologies for stealing from one of my favourite films, Up, but if we have good relationships and quality relationships, our lives are better. And having access to quality relationships is a really important determinant in terms of keeping older people healthy and well and independent, whatever setting in which they live. And finally, last slide, please. We need to start getting on with this, because we know from the limited interventions that we've managed to take forward as a very small charity with very limited resources, we have a massive impact on the lives of the older people that we're able to support. And our plea is we need to really start seriously thinking about how this low level intervention is going to have a massive impact, not just on the lives of the older people that we support, but also in terms of the demands that will be made on health and social care in the future. Thank you.
Andrea, that was fantastic. I think my delay was from my awe of the presentation, and it wasn't Zoom, it wasn't Teams holding me back. But that was fantastic, and I think you've kind of really started us off in a fantastic way by giving a really good example of how a charity like yourselves can come together and really make a difference for people in the community. But also how you've kind of changed pace and how you've changed the way you deliver things like so quickly with and the bringing on board of what sounded like a digital coach in aid and how that person kind of was able to support the people that you kind of work with to really make the most of the services that you're offering them. So that was amazing, and it was really good to kind of see that really clear evaluation framework in place as well. And there'll be people on the call. You know, this is kind of National Value in Health Week in Wales, so there'll be people on the call who are really really happy to see some of those things in place. So I'm going to stop hogging the floor, because I could ask loads of questions myself, but and I'm going to put it out to the members. And then I can see Adele. I think Adele Harhill. I can see that you've got your hand up. Did you want to ask a question, Adele?
Yeah, lovely. Thank you, John. Yeah, and thanks for that, Andrea. That was fantastic, really inspiring to listen to. I guess 2 points for me, and I might have missed it in your presentation, was, you know, how are you now working with the NHS in Wales to offer those services in terms of partnering for that joint value? And the other point was, you talked around collecting outcomes in the future, and you already have a validated tool that you've mentioned. It was what technology are you thinking of using, or do you already have a system around that?
I can answer the first question more easily than the second. So in terms of the first question, we'll work with any statutory services that are prepared to work with us. In common with a lot of third sector organisations, the bulk of our funding actually comes from grants and foundations into whom we bid for money. We have had quite a long-standing working relationship with the Swansea Bay Health Board, and we have an emergency relationship actually with an Iron Bevan. But like so many other small charities, it's actually making those initial contacts and actually making people aware that we exist and what we're able to provide. So anything that anybody on this call can do in terms of helping us access those opportunities, we'd be incredibly grateful, because I do think we can add value. With regards to the second question, we've actually invested in our own researcher, because we feel very strongly that there's so many interventions that go on, and I think the third sector is one of the parts that tends to be the most guilty for not actually robustly evaluating what they do, and that's a massive disadvantage, particularly when you're looking at bidding for funding in the future. So we've taken an approach from the outset that everything we do will be robustly evaluated, and it has been independently evaluated as well. With regards how our researcher crunches the data, I'm afraid I know she uses technology to do so, but I don't know what the technology is. I just make sure that the individuals who are participating in the programmes that I'm supporting fill in their evaluation sheets, and that we where we're working with staff within an organisation, we do provide training for the staff within that organisation on how to complete the evaluation data. So, for example, we're doing a project with Park Prison at the moment, and we have their healthcare staff supporting the prisoners who are participating in the programme and filling in the questionnaires so we can gather the data properly. Again, not just putting questionnaires out there and expecting them to be filled in without any sort of level of support. But in terms of what programmes we use, I'm afraid I don't know. On a need-to-know basis, I didn't need to know. But yeah.
That's fantastic. Thank you for that. I think we should connect.
Absolutely. I will make sure that Jonathan sends my email address to anybody who wants it.
Brilliant. Thanks, Adele, and thanks for answering that, Andrea. And I'm just going to ask, so where are you currently where are you kind of working across Wales? Because we'll have people on the call who are from, you know, various health boards, and will have probably interest more at a local level. And are there, you mentioned Swansea Bay and Iron Bevan. Are your activities spread across Wales at the moment?
Yeah, the one programme that we're running, which is still running remotely, because obviously we're a very small charity. We don't actually have any full-time members of staff. We all work on a sessional basis because we all are completely reliant on grant funding to run our programmes. So we try and run a very tight ship so that all of the funding that we generate goes into the provision of services and support of older people in the community. But we've got projects, Swansea, Newport Talbot. We've just got some new projects starting in Rhondda and Taff. We've worked for a good while in Cardiff and the Vale. We've got new projects in an Iron Bevan Health Board area. We've managed to get some funding to get a community outreach worker in Powys who is busily building projects for us and looking at sources of funding for those projects. And I've got 2 care homes in Anglesey who've been participating in one of our virtual programmes. So the virtual programmes have actually been a massive opportunity for us as such a small organisation to get that spread that we wouldn't be able to do if we were having to send members of staff or sessional workers across Wales to deliver our programmes face to face. So technology has been really positive for us, and that's why we're determined we're going to continue to have a good quality remote provision still available for communities, which particularly the more isolated coastal and rural communities where you don't necessarily have the number of people to participate, or certainly access to tutors who would be able to deliver our programme.
Absolutely. Well, I think, you know, I can probably say on behalf of all the members, it sounds like you're doing an amazing job, and you know, if with the resource that you've said that you have, I think to achieve those outcomes is no kind of small task. So, you know, well done, and I think keep things moving along as best as possible. Bill, I know you have a question. I'm going to keep things moving along, so I wonder if you could put it in the chat, and maybe Andrea could answer it there for you. Andrea, do you mind putting your email into the chat, and so that people have access to it instantly then, and
yeah,
it might be stop any delays in getting those emails out to everyone.
Yeah, I'll do that now. Thank you very much.
Thank you again, and thank you very much, Andrea, and for an amazing talk. And it sounds like you're doing some really awesome work with you know, the communities across Wales. So I'm going to move us along to our next presentation. So with the title being "The Cat's Out of the Bag: Using Robotics to Reduce Anxiety and Social Isolation." It wasn't my title to put on it, and it was one of the presenters who very kindly came up with that. So I'd like to introduce Aimee Twinberrow, who's one of our project leads from Life Sciences Hub Wales, and Jim Murphy, who is the CEO of Ageless Innovation. So I'm going to stop talking and I'm going to hand over to you, Aimee.
Thanks, Jonathan. So hi everybody. As John said, I'm part of the a project lead within Life Science Hub. So today me and Jim are going to give a quick overview really of what we believe the robotic cats and dogs can do. So Jim's going to initially kick us off with a little bit of more information about the product. I don't like calling them products, they're more pets, but we'll go into that. And then I'm going to provide a bit more information about where we've actually used these in Wales so far and what the vision is really for the future on them in my kind of eyes. So Jim, I'm going to hand over to you. Hopefully you can present. If not, I have it backed up.
Sounds good. Thank you, Aimee. And I'm going to share my screen. And because I'm not very good at multitasking, you're going to hear me go quiet for a moment. Can you all see my screen?
Yeah, I can see that perfect.
Okay, that's great. And yeah, so 2 quick things. So Aimee, I did not see the title ahead of time and absolutely love it. So wish I could take credit for that. And 2 is I actually head up our healthcare business within Ageless Innovation. My boss is the CEO. I appreciate the promotion, but so I'm pleased to be able to share information about Ageless Innovation and our Joy for All companion pets today. So really begin every sharing with our purpose statement. And our purpose is to reimagine how we positively live and age together by unleashing the power of play. And for folks like yourselves and myself who have spent over a couple of decades really focused on serving and supporting the senior population, older individuals and their caregivers, that purpose statement might seem a little bit strange relative to other purpose statements, mission statements you've seen relative to senior care. And when we talk about the origin story of the companion pets, I think it'll make a lot more sense. So I'll give a much abbreviated version of this timeline for sake of brevity, but the Joy for All companion pets were birthed within the walls of Hasbro, the toy company that you all are likely very familiar with, has thousands of different properties and assets. And it was founded through a consumer insight about one of their existing toys that was targeted for primarily for girls ages 4 to 10, and it was called a For Real Friend. And through a consumer insight, the team at Hasbro actually learned that about 20% of purchases, a meaningful number of purchases, were actually for an older loved one. And they took that insight about 5-6 years ago and began to work with older individuals and their caregivers, their carers, care partners, to be able to understand the value proposition and how it could serve and support those individuals. And so with that, through that research, the Joy for All brand was launched, and it began with a robotic companion pet in the form of a cat in late 2015 or into early 2016. And as you can imagine, it was really focused on those channels that Hasbro was used to and leveraging those channels, retail and direct to consumer. And so as they leveraged those traditional Hasbro retail and direct to consumer channels, what happened was some of these customer reviews quickly got on the radar screen of folks at different healthcare and academic organizations. And I was one of those individuals. So at the time I had an innovation role in United's healthcare division, and the companion pets were introduced to me, and I, although quite familiar with animal assisted therapy, have to say that I started off with a bit of skepticism. But the more I delved into these consumer insights and organic videos that were being created when people were gifting them to an older loved one, the more I became intrigued and ultimately proposed and led a study within United. There were many studies that were in motion. We now have over a dozen studies that have occurred throughout the US and internationally. And so in 2018, that small team within Hasbro had a friendly spin out, founded Ageless Innovation. Our flagship product and our focus today is on the Joy for All companion pets. We continue to grow both the retail business as well as the healthcare business, both domestically within the US and internationally. I'll share a little bit more on that. So for sake of brevity, I'm gonna refrain from showing the demo videos as well, but happy to provide links to that. And for those that aren't familiar and haven't seen these robotic companion pets before, they're intended to be as lifelike as possible, but still at an affordable price point. So the cat acts like most cats in that it has a random play pattern algorithm, and it's not going to do exactly what you would expect relative to your interactions with it. But basically, what it does is when you interact with it, it's going to meow, it's going to preen itself, it's going to roll over, and it also has something called VibraPurr technology. Knowing that this purring was an important part of what we heard relative to consumer feedback, and it had a very calming effect with older individuals, specifically those with dementia. Next, I'm going to describe the pet, the pup, which was launched about a year to 18 months later. And like most pups, it really does what you would expect it to do, in that its play pattern is programmed to be able to be directly responsive to the interaction that you have with it. So it has what's called bark back technology, where it's basically going to respond to your voice. And as you interact with it, it's going to bark back to you. It's also got a responsive head and tail movement, and it also has a, similar to the VibraPurr technology, a calming heartbeat. So, as I mentioned in the beginning, when these pets were launched through Hasbro, and today, like many consumer products, on the retail side, our biggest distributor is Amazon, but we have many other distributors, both through the U.S. and in the U.K. as well. On the healthcare side, we have a foundation of these dozen or so studies that I reference, some larger statistically powered studies like the AARP United Healthcare study that was done with the Medicare population, the study that I proposed and led, and others that are smaller and more qualitative in nature. But I think what you'd find here, regardless of setting, is that there are two primary use cases that we've seen to date through these studies and through the general use of our pets and consumer feedback, which is, and the first one to really reveal itself was the positive impact it can make with older individuals with Alzheimer's or other forms of dementia. And then two is those individuals who may not have cognitive issues, but no longer have the ability to be able to take care of a pet for a variety of reasons, and specifically those that are socially isolated and lonely. And that was really the crux of the study that I led at United, and the findings, both qualitatively and quantitatively, really showed the pet's ability to move the needle. So when you look at the studies, and I'd be happy to provide links to the studies themselves. So I know that was quite a roll-up view and really just headlines of the findings, but I'd be happy to provide the studies themselves if anyone's interested in learning more about any or all of them. But when you think about the roll-up benefits, the psychosocial benefits of the pets and the impact they make, and using various different measures in different studies, it's all about reducing feelings of depression, isolation, and loneliness, help to provide a sense of purpose, mitigated dementia-related decline and associated behavioral issues, provided an engaging experience that calms individuals with the use of without the use of medications. In other words, a non-pharmacological intervention, and improved cognitive activity and capability as reported in some smaller studies, and reduce the burden of care, knowing the B word is a word that we look to avoid when we talk to consumers, but when we talk to other folks within the industry, burden of care we know is a measurement that's used relative to care partners, both professional and family caregivers. So I'm going to play a short video that highlights a program in another part of the UK that I think will be a great jumping off point relative to the conversation Amy's looking to lead us in.
I looked at her, my heart went for her.
Why is she so special?
I don't know. It's something that's unusual. I never saw a thing like that. She said hello. Hello, darling. One resident who continuously walks around will now sit down because we'll cuddle with the cat, speak to the cat. And as I say, a lady where it started was non-verbal, who is now trying to communicate with us.
Little blink as well. If you tickle underneath, it will roll over onto its belly. And now I've got them rolled out across the whole of Mid and South Essex.
300 cats?
About 300 at the moment, and you know, it's not just for care homes, it's actually for the patients' own homes as well. We've been given to our community dementia teams. We have community nurses out there, and they've been giving them to patients in their own homes.
There was many residents in our research that were aware that it was a robot, that it wasn't real, but they still gained comfort and joy from it being reactive and it responding to their touch.
Okay. And Aimee, with that, I will turn it back to you.
That's great. Thanks, Jim. Thanks for that. It was lovely to see Mary in the video, and that brings me really on to our conversation today. There are going to be many more Marys, hopefully, over the next few years. We know that there are Marys out there already. So let me quickly share my screen a second. And I am conscious of the time, so I will keep this very brief. So hopefully you can all see that. Yep. Okay. I won't go into my background, but essentially I've come from social services for many, many years as a qualified social worker, joining the Life Science Hub. So with that background in mind, I won't go into some of these projects today, but I am happy to speak about some of the projects that perhaps I've done in my previous role and how that might impact some of the work that you're doing, or if you want to share some learning, I'm happy to do that. But essentially today I'm here to talk about the robotic pets. So why am I here today to talk about that? Well, like I said, previous to the Life Science Hub, I worked in Torvine Social Services. We had an idea at the time. I used to manage a domiciliary care team. We had a dementia specialist team, and we noticed that there was a real need in there really for kind of carer support, and we were keen to look at different ways of working to enable people to continue living at home essentially. So what did we do? So we applied for ICF funding in Torvine, which was successful, and that's how we accessed the funding to buy some pets initially. Since we did the initial funding, there's been further rollout across Gwent, and then we're now looking at, you know, around hundreds of pets going out across Gwent. And what we did, we assessed people in social work assessments, or when we were doing lifeline assessments, for example, within our technology service, we would think whether or not we thought someone might benefit from having a robotic pet. And that's how we kind of identified anybody. We kept the criteria quite broad initially, just because we didn't really know what we were doing. We didn't know where the scope was. It was really new to us, so we were kind of keeping it as broad as we could. And what did we kind of learn from it? There was lots of learning points actually, but one of the key learning points was that initial introduction of when you're bringing the pet into somebody's home. We found that needed to be managed quite well. Not everybody took to the pet, but I would say on the whole that they did. So that needed to be managed. It needed to be kind of monitored by a social worker or by our own kind of lifeline installers. And what else did we learn? We learned that they were obviously run by batteries, so they needed to be replaced. So that was also something you need to be mindful of when we're working with robotics. And the fur needed maintenance, so that needed a bit of brushing, a bit of upkeep sometimes. But generally, they were the kind of the hands-on learning points. But one of the key things we did, and we didn't do great, was the evaluation part, and that is what I'm keen on doing in the future, is to evaluate our services much better. Particularly when you're looking at social services. Unfortunately, we do these things normally on top of our day jobs, and trying to fit in the evaluation on top of everything else can be really difficult, and that's something I want to look at. And what did we learn? Well, I won't go into these too much because Jim has beautifully covered these in his presentation, but essentially we found what everybody else found. We found that it lowered levels of agitation, it lowered the use of PRN medication, it reduced isolation for people and loneliness, and communication with people improved. People were able to actually remain at home for longer or remain in their placement because their behaviour altered. We found really positive impacts from having robotic pets, which is where it leads me on to the next bit. So that's great, but what do we do next? So for me, working in Life Science Hub, the next steps are to look at some kind of national rollout. Like I've said, we've done it small in Torvine to then Gwent, and there are little pockets around Wales, but how can we share that learning nationally? how can we roll out these benefits nationally? And that's something that I'm going to look at. So I'm looking to all of you here today and anybody in Wales to set up some kind of working group and look at how we can do this. I'm keen to get a national research done on it so we can provide benefits for costing, so we can build these into kind of care planning and into our actual kind of, you know, how we deliver care. So at the moment I'm speaking with industry partners, so I'm speaking to people like Jim to look at how we do the next steps. So I'm going to be attending a few more of these kind of meetings to try and gauge some interest. So if you are interested in kind of embarking on this next adventure with us and trying to spread some of this learning and spread some of this joy across Wales, then please get in contact with me and we can look at the future really. I will put my email address in the chat as well. So I'm just conscious that I want to keep us on time today. But if you do have any questions, I will stop sharing my screen. I'm more than happy to take any.
Aimee, Jim, that was brilliant, and I think we've got a question, and I think that in the chat there are people kind of, I suppose, hoping to link up with you and kind of get some more insight into what you've been doing. So, Bill, I'm gonna pass to you for the first question.
Thank you. The social return on investment model, I'm working on that at the moment, so I need to connect with you. But also the cost of not doing it is something I do as well. So we can have a chat about that. Thank you.
That sounds perfect. Thank you.
There you go. Brilliant. Thanks, Bill. And I think, Jim, thank you very much for joining us. And I hope, you know, you can join us in future events. But I think it's really exciting to see these types of, you know, innovation and technology really, I suppose, taking a different slant on how we can support people in the community and, you know, and the population, and social isolation and loneliness is a big thing, and I think we've seen it really at its height over the at its biggest point over the past 18 months. But I think there's still a huge amount of work to be done and a lot of learning to be done, and I'm sure, Aimee, that, you know, there's opportunities for this type of technology to be used in settings that haven't been looked at already, and I think, you know, and I suppose those become opportunities for us then in Wales. And like you said, there's a call out to members to get in touch if anyone has, you know, feels that there's a place where they could make use of this and learn alongside you. So brilliant. Yeah, really good, and another good example of how technology is supporting the health and care system. So thank you very much both, and fantastic. And if you don't mind putting your emails into the chat, and then again, it just saves that a delay on people getting in touch with you should they want to. So
thank you. Thanks, Jim.
Thank you.
Thank you, Jim. Okay, right, so we're going to move straight on. Two brilliant presentations so far. So I'm going to move straight to the next one. So we've got John Griffiths from Safehouse Technology joining us next, and John's going to talk to us. And John's a long-standing member of the Innovation Network, and you know, an active member of the Innovation Network. And John's going to be talking to us today about falls detection and the Safehouse technology that can support with falls detection. So over to you, John. And like I say, I'll be quiet now.
Okay, thanks, Jonathan. Yeah, John Griffiths here. I'll just try and share my slides, if I may. Right. Hopefully you can see this. Hang on a sec. Hang on a sec. Let's try that again. Where's desktop? Can you see this now?
Yeah, we can see those. It's not in presenter mode, but we can see them.
Can you see it now?
Yeah.
That's in presenter mode. Hi, my name's John Griffiths. I'm CTO of Secure Sensor Innovative Design Limited. And I started off as technology specialist for the Welsh Government back in 1998. And in 2003, my mother contracted early small vessel dementia. So I moved over to be the assisted living specialist for the Welsh Government until 2011. And what we found was actually keeping mum at home was a priority and something we really wanted to do. However, the technology in those days was not really up to it. It was more trying to keep people safe as opposed to help them live longer in their own homes. So in 2013, I set up SSID to look specifically at technology which could address this issue and essentially prevent people from going into either secure accommodation or secondary care. So our main product is called Safehouse, and this is an Internet of Things project, which a lot of people talk about. It basically means that everything can be connected via the internet. And we've taken a slant of specifically looking at integrating health and well-being with smart city technology and property management. So the whole idea is that your home is the place where you feel most comfortable with. Traditionally, these sort of interventions, smart home, ring, hive, have all been very, very vertical and sealed systems, and sometimes quite expensive. While the Safehouse system is designed from scratch to actually use open free protocols like LoRa, which is now becoming much more common as a method of communicating with the home, and then opening a platform which was truly open for the future, where you could build sensors which would connect to it, and you don't have to worry about how that gets back to the main app to be used. It's all GDPR compliant, and it allows people to look to the future and look at things which basically would give you an end-to-end solution to staying longer in your own home. So, as I mentioned, it's an end-to-end IoT solution with cyber security is totally at its core. And what we do is we allow Safehouse there to actually connect to the cloud using a network which is referred to as a LoRa network. And the LoRa network is becoming much, much more popular around Wales. The Welsh Government has just put out a lot of antennae, and it's an alternative to the GSM network in that it's effectively free and works very, very well for small amounts of data. And all you need from somebody in their own home is actually quite a small amount of data. Things like, are the lights on? Is the person moving? What temperature is it in the house? What's the humidity? Is over 70%, you start getting COPD in long-term conditions. And also things like carbon dioxide, which I'll come into in a minute. But what we also did in Safehouse was we actually decided that it was better to have your relatives and loved ones in connect with the person. And in many ways, as we've seen in Action for Elders, this is the electronic side of that, where you can make sure that mum is safe at home just by looking at the app first thing in the morning or last thing at night, and also knowing a lot of detail about if she's lonely, if she's immobile, or indeed in many cases if she hasn't, nobody's visited, which is really the first sign of depression and loneliness. So it helps in actually giving all this information to the end user. So what is Safehouse? It's a little discrete data aggregator. It's a little box, and what it does is it connects to the cloud, secure cloud resources, and it fuels the data. The data fuels essentially alarms and alerts for the app, and also for an alarm response center. As you'll see in a few minutes, we've actually taken this a lot further. And one of the main things we found is that if you know the temperature is good in the house, the humidity is good in the house, and your mother's moving around as she should be in a pattern, generally it allows her circle of care, people who she'd like to have visit them, basically get in touch with much more active data relating to that person. So basically what we did with Safehouse, we actually produced as data aggregator, but we actually used Bluetooth for the sensors. So this meant that any sensor that you find which may be suitable to personalize somebody at home would actually be connected to Safehouse and then connected to the app. So at the bottom of the screen there, you can see the traditional panic button. However, next to that, there's a door.
John, sorry to interrupt. Your slides aren't moving along. It's still on your first one, so I don't think it's on presentment. I wanted to stop you because I wanted people to see the unit, so they could get an idea of what it looked like.
Okay, so I take it off present and go to the other one. Why don't I do this?
Yeah, perfect, wonderful.
Okay, sorry, that's Teams.
Sorry to interrupt you.
No, that's fine. Sorry, that's the end-to-end Safehouse solution sitting there. There's the cloud-based environment, the alarm center, the response center, and there's the app sitting on the side. The app is free to download to anybody who's looking after a service user as well. So there's, it's all incentive to look after somebody and keep them happy. So there's the Safehouse unit itself. As you can see at the bottom of the screen, there are 3 sensors there. This looks very much like a Bluetooth, a USB sensor, which it is, but rather than connecting your keyboard to your laptop or your mouse to your laptop, it actually picks up temperature, humidity, light, carbon dioxide, VOC levels, air pressure and noise. So if you place that in your mother's bedroom, you can tell really how she is, how she's sleeping, what time she's getting up, things like that, very accurate. This in the center is a door sensor, so you know if somebody's actually visited on that basis. And then finally, on that, you can have the traditional panic button alarm. So how does this work in practice? Well, quite a lot of traditional telecare was a single unit with basically an alarm pendant. And I'm sure we're all familiar that most people didn't really like those, and they really are a bit limited in today's world. So Safehouse, what it does is have sensors in each room, and basically it picks up if you're in the kitchen, in the hallway, bedroom, if you're in the living room, or if you're spending a lot of time in the bathroom. So in this way, we can actually find out if somebody has fallen, or if they're immobile in any shape or form, then they can actually be picked up by the environmental sensors. These sensors are battery powered, and they also pick up the temperature, humidity, light level, sound level, and movement, along with CO2 levels and volatile organic compounds, to get a really comprehensive idea of how that person is living in their own home, and to make them actually feel really secure that they can stay living in that home for longer, because if anything really happens to them, then they know that there'll be somebody who can actually come and call very rapidly. Or indeed, if they just basically don't feel like getting up in a particular day, then somebody in their circle of care can come and visit, and they've been visiting. So really addressing their mental health and keeping people safe in their own home. So what does make your home safer? Well, first of all, many people don't realise that there's a lot of invisible hazards in the home, specifically in the bedroom. When people fall, there's normally either, 3 places: bathroom, bedroom, or in the lounge. And one of the main issues in the bedroom is actually a build-up of CO2, which can be as a result of somebody actually having the bedroom too cold, and as such overnight the person works harder to stay warm, and when they get up, then the CO2 levels can be very high, meaning that there's a very good chance that they won't remember to switch the light on, or more fall over their slippers, in many ways being slightly drunk first thing in the morning. So we actually mitigate those by actually identifying high CO2 and high volatile organic compound levels and movement, so that you know that basically your loved one is safe in their home and preventing actual falls. The technology has to be universal and open, and Safehouse does that by having non-invasive sensors. So we don't use wearables, we don't use those sort of things, because why would you change somebody's home just because they're getting old? So quite often what you'll find is people are quite happy with these sensors because they don't do anything. They just sit in the house and they monitor movement and things of this sort. But realistically, once explained that it does keep you in your own home longer, that's a really good thing, and also allows the people to early intervention on things such as possible lights which could go on automatically if somebody gets up in the middle of the night, and also looking at the number of visits to the bathroom if they've got potential UTIs or things of that sort. So really we give confidence to people that they can go not only in the home, but there's also assistance buttons, and these assistance buttons are quite small, but they have the ability to actually tell you where you are using a GPS locator. And if you press the button, what actually happens is that you can be out, and an alarm response center can say, well, actually what's the problem? You say, well, I'm just confused, I don't know how to get home. And then what would happen is that then you could assist them by talking them through the way home. And finally, the most worrying thing is obviously keeping the home safe just in case you've fallen. And we have a fall detection system, which we'll come on to in a second. But obviously, the quicker the response, the quicker recovery. So how does this smart technology help to keep you at home and prevent things? Well, the invisible hazards are picked up by this USB sensor, and that's great for in the bedroom where all of a sudden things like CO2, which is the unseen killer, really can be totally ignored and you don't realize that that's an issue. And also with the idea that the temperature and humidity is at the right temperature in the bedroom as well as in the lounge. Quite a lot of people visit the lounge and then, you know, the older person might be going to bed in a freezing cold, damp room, which is no good for the long term. The Safehouse system is really very easy to put in, and really most of our users don't even see it as any type of monitoring whatsoever. And that's because we use the Safehouse app, which allows people to create their community of a circle of care and then chat like with WhatsApp to each other. And then so somebody who's right next door to mum, for example, if she's pressed the alarm button, might pop in and say hi, or if nobody had been in that day, might pop in and say hi. Everybody in the community knows about that, so it gives a lot more confidence to the person being at home to stay at home. And this is where we were asked by Glasgow City Council to produce a falls detector. And the falls detector itself is something I'm going to come on to in a minute, but it was really a combination of about £200,000 worth of R&D to look at how you can keep people at home and stop them being lonely. And after all, falls do cost the NHS £1 billion per annum. The prognosis, having fallen and possibly broken your hip, is not life-changing quite often and can be very debilitating, let alone confidence, of course. So what I'm going to do next, whoops. Right, so this is something we've developed which is called the Toothpaste App. And the Toothpaste App is something which you look at twice a day to check that mum's okay. And basically what it is, it's the ability to have 15-minute segments of what mum has been up to in the day. And here is the front door and how often that's been opened and when. So these are 15-minute segments, and these are areas where mum has been, to the bedroom, to the bathroom, and then down into the office, for example, or in the living room. So most people, when they look at this, can almost straight away say mum's fine. She's out walking around the house, she's going to the loo not too often, she's spending some time in the kitchen, she's in the living room watching her favourite programmes, and, you know, the carers have been. Very simple stuff. But what we also add on to this is these are all green, but if they turn orange, then it shows that either the temperature or humidity in that room is too low or too high even. And as such, you can then start making a decision as to whether mum's actually warm enough, whether she's actually safe. And quite often you'd find that the actual areas where mum goes, or the older person goes, they often have to be that sort of temperature to keep, you know, in today's world with bills going up, anxiety towards bills, quite often, you know, you don't mind chipping in to help for the bills as long as you know the house is warm and she's safe. So going on to Glasgow, this is a falls detector which we were contracted to build for Glasgow. The one on the left is what we started with, which is basically it's a falls detector that will not use Wi-Fi, wearables or cameras. It uses infrared, and the infrared itself actually notices when the person has fallen over. But it was okay building this, but it had to be at reasonable cost. How much would it cost to actually make sure that you knew if mum had fallen over or was about to fall over even? And so we went from looking at this to a consumer model, which you can see on the right there, which is just currently won the Tritech Challenge very kindly from Hull Health Board, to look at falls and the way in which falls can be detected not only in the home but also in hospital environments, and then going from there in wards and things like that where you might not have somebody on full time. Normally I would show you a video. I don't know if this will work. I don't think it will, but I'm trying. Yeah, maybe it will. Yes, so this is what our falls detector would see, and basically on the left is an infrared image, on the middle is our AI image, and on the right is our AI image enhanced to pick up the actual person falling over by the velocity of their skull. So unlike any other falls detector, such as a wearable or anything like that, it covers the whole room. You don't have to wear it wearable. It doesn't require Wi-Fi. And the good news is in Scotland, it was greater than 95% accurate as indicating somebody had fallen, and then opening a voice channel in less than 20 seconds. So with regards to response, it's very good. You obviously didn't see any of this because it's all hidden in the box, but people don't believe us otherwise. So what is the market? We believe that the digital switch off in 2025 is going to be very significant in that you have to go to digital equipment. So almost all the telecare equipment around is going to have to be changed. We think we've got the platform which is most useful for that. And we've got a lot of interest from some of the traditional telecare companies that are looking at licensing this from us. But the most important thing is that we believe the platform itself is the platform for the future that will keep people safe in their own homes 5 years plus, by making sure it's maintained, heated, and at a level which is acceptable to rather than going into secondary accommodation. Sorry about Teams messing me around. That's me, John Griffiths, and more than happy to take any questions you may have.
Thank you, John. Yeah, another good presentation. Some really interesting points, and you know, I was at the Tritech event, so it's great to kind of hear about that, and also just to kind of hear that again as you sharing that information about the technology, and some exciting things ahead by the looks of it. And that wasn't a pun, as in, but yeah, and some really kind of innovative kind of ways of looking at how to detect falls. And something which you said, which was really interesting was about that, how it allows that communication channel between the faller and the person in the background. And then been in conversations with kind of people who manage falls across Wales, and that's something that is kind of missing from some of the technology, to be able to have that communication with someone who has fallen, to really understand the extent and what support is needed. So that's a great addition, and something which I think would be appreciated by those across the system. Does anyone have any questions for John? And I'm going to open it out. Mark Briggs, nice to see you.
Yeah, hi there. Thanks, John. That was really great, and it's amazing to see where things are going, as everyone else has said. So I'm Mark Briggs, Assistant Director for Innovation within Cardiff and Vale University Health Board. I just wondered whether or not you'd had any sort of negative feedback on the systems, in the sense that as they become more and more sophisticated and you're sort of tracking or can track people's sort of movements, whether or not you touched upon maybe like social isolation because there's less incentive for people to check in, or almost that it's almost a bit like Big Brother watching me, so I can absolutely see the benefit, but I just wonder whether or not anybody has ever sort of pushed back, and whether or not there is a sort of a compromise or a sort of middle ground for those individuals.
Yeah, this was a big issue when we first started doing this, and they're saying that the one thing is that am I being tracked or am I being watched? This is a pre-production prototype sensor. These are now about a quarter the size of this, and they have no lights or anything on there, and they basically sit there passively in the room. You normally forget about they're even in there after about the first day or so. What is interesting is that the take on this is twofold. It's basically obviously fuel poverty is a huge issue, and people don't talk about that. And so being able to know that the house is warm and they're not going to have COPD is hugely outweighs the benefits. But what we've discovered in Liverpool is that people don't talk about that. And we had a situation where the carers were going in, everything was fine, this gentleman was there, but he was only switching the heating on for the 2 hours before the carers turned up. And then what was happening was he was not leaving the house because he couldn't afford to. And there were all these sort of things. The other interesting thing is what you don't see by having this. In many cases, going to the loo a lot is a very, is a key find for somebody not being well, but they'll tell you you're fine. And we haven't really had a pushback from this at all because we don't use any cameras, and people know that it's totally passive. Unlike changing their lifestyle, we like to enhance their lifestyle and say, and that seems to be outweighing any negatives that we've had at all. One of the interesting sidelines of it, though, is that when you do know the activity of people in certain rooms, you can actually pick up people with early stage dementia, because what they'll do is they might start, as in my mother's case, sitting in a room which you wouldn't have thought they'd be in for an awful long time. And she used to spend 8.5 hours in the dining room. And every time I'd go into the dining room, I'd say, well, she's fine. She's got the paper. She's sitting down. She's in the dining room. If I'd known she'd been there for 8.5 hours, that would have been a different story. And the reason she was there for 8.5 hours was because she was psychotically seeing a family on the end of the garden wall and wouldn't go to bed until they'd gone, just in case they stole something. But none of us picked up that at all. And it would have been a really straightforward trip to the memory clinic if that had been picked up. And so there's, I suppose in many ways, you don't know what you don't know. And we're in the early stages of using this, but more than happy to work with guys, because the model we see has been pushed forward by Scotland, is to use artificial intelligence to find people who have dropped out of the norm. And therefore you can do it at great scale. And what's going to happen is there's 160,000 telecare users in Scotland. You're never going to be able to check up on each one accurately like this, but with AI you can then pick up trends, which is a normal trend for that person, and then turn around and say, okay, they're fine, they're in their trend, they're not changing. But it's when they fall out of that and you don't notice is when you have the real problem, and that's what we're trying to prevent.
That's great. Thank you. And I know we're suppressed for time, but just make a quick follow-up. Are there any other sort of modalities that you'll be looking to sort of introduce then? You've got the camera. Are there any other obvious measures as technology catches up that you want to integrate into the system?
Yeah, I think the only one we're really interested in is we build these sensors ourselves. We design and build them ourselves. So the sensors, the environmental sensors, do just about everything you need to know. The missing point of it is the water usage, where we believe that water usage connected to all this would very rapidly pick up UTIs and also the ability to pick up early stage dementia. Because, in my father's time, old people didn't smell, smells because they couldn't cope. Well, if they stop using water, that's a really good indicator that somebody's actually not doing that. And that's something I've been very passionate about for a long time. And I think that's really one of the things which can make, an ideal situation. So in the Arwen project down in Swansea, where I'm on the Swansea Uni, I'm on the steering group. That's one of the things we can look at is how, if somebody has changed their water usage, how that can have a direct impact on health.
So that's fascinating. Thank you very much.
Hey, no problem.
Yeah.
Thanks, Mark, and yeah, two great questions, I think. And to go back to your first question to John, I think it just shows, doesn't it, how technology moves forwards. I think the conversations need to change with people in our population about how, as a physiotherapist, when I work on the wards, patients want to go home to their own homes, and that was always a big thing for patients. They wanted to go home, and I think that the conversation is going to have to maybe move that much further forward to say, well, what can we put in place to help you stay in your home? And I think it's about how we all kind of worked to kind of make the technology do what it can do, and hopefully that develops alongside the technology in itself. So.
Yeah, technology really is becoming so much cheaper and so much more reliable that people are entranced in the old idea of telecare and trying to keep people safe by pinning them to their own homes. Well, we're trying to get them out and give them more confidence to go and do stuff. But the message is the complete reverse. You know, if you're out of range of your pendant, you know, are you safe? And you know, it's rather a childish mentality of trying to, you know, take them back into the school days of being, you know, and we believe that shouldn't be the case. It should be the complete opposite. Anyway.
Wonderful. Thank you, John, and great to see you. And thank you for that presentation, and thank you for the questions, Mark. So I'm going to move us along, and it's actually my turn next. So what I wanted to talk to everyone today about was, so over the past 12-18 months, we've been kind of talking to members, and part of the meetings that we've been having have been asking you as members what's important to you about joining the Innovation Network. What are the functions and the outcomes and the outputs that you'd like to see come from being a member and joining these meetings? And that's been really valuable, and it's helped us understand how we can continually improve the network so that it delivers these kind of functions and opportunities for you as members across Wales and further afield. But one of the things that kind of kept coming through is about kind of networking and about having that insight into some of these newer innovations and understanding what's out there and what's being done. So what we've been doing recently is working out, you know, ways in which we can do that, and there's different ways, and you know, we're trying to encourage more kind of member interaction with during the meetings. But what we've done recently is we've been working with one of our partners who are members of the Innovation Network, so Simply Do, to create what will be an online space where members can go to have those kind of follow-up discussions and network a lot more confidently and in a safer place. What we've developed in our Simply Do platform is a Innovation Network members group. So I'm just going to share my screen just to kind of give you a bit of an idea of what that will look like. So if you bear with me 1 second. So you should all see the Innovation Net with a Simply Do platform, which is the Life Sciences Hub Wales Simply Do platform, and it has the Innovation Network Health and Social Care Wales members group. Now, it's a very simple idea. What we're hoping to do is that members can sign up to join the members group, and it will have a discussion board where people can share and can comment and have a discussion around things after the meeting. So we can take some of the conversations like from today's prevention meeting and take them into the group so that they're continued and we don't lose momentum. We can share ideas, and we can share you know, things about opportunities that come up from an innovation point of view, and it will just allow us to have those opportunities which we kind of haven't been able to, where we've been delivering this virtually now for the past 12-18 months. And it just gives members that opportunity to kind of follow up and have a little bit more of a chance to kind of interact and get to know each other and share and kind of learn from each other. So what you can see on your screen is kind of the home page, and there's a discussion which, you know, there's different discussions which can take place, and we'll have the purpose statement for the network that will be there, and we can then also share any resources that we have from the meetings and presentations and any information that comes from presenters. So it's all in one place for people to go to. Part of the innovation group will be that members have sight of who other members are, and you can contact each other through the chat, and you can create your profile saying what you're interested in and kind of what areas you work in, and it just allows it to be a lot more kind of open so that we can get to know each other and we can essentially learn from each other. So the network actually starts to feed itself and become a much more community-based approach, and hopefully feeding into some of those desires that were coming from the members about how we can improve the network to kind of, so you can get the most out of it. And that's around that networking, collaboration and kind of insight into innovation. So what we're going to be doing after this meeting in the next week or so is what we tried to do is we want to get a test group to go through it. So a small cohort of about 35 people. So some of you as members who are, you know, longer term active members will be getting an email from us with an invite to join the Simply Do network group. And what we're going to do is we're just going to run it for until the new year, just to get an idea of how it works and how we can engage people and how we can encourage kind of conversations and discussions. with the idea of getting some feedback from those who've been involved, and then the idea being to open it out to the wider network in 2022. So in January, hopefully before the next meeting, which is in February. And again, that's just to make sure that there's no we're doing it the right way, we're getting the right things up there, we're engaging you as members to come back to the group and have really good, meaningful discussions and sharing meaningful opportunities. So some of you will be getting an email over the next couple of days, and for the rest of you, we'll be feeding back to the group about what that process has been and what the feedback's been, and hopefully being able to share that with everyone then, so it becomes everyone can get involved and everyone can contribute. So I just wanted to share that with everyone because that's something that we're quite excited about. It's a new addition to the network, and it's not fancy, but it's there to kind of support you as members and also support Wales and the innovation ecosystem to just really try and help us collaborate a lot more and also improve that sight of what's happening across Wales. So, and carry on those conversations from the meetings like we've been having today. So I'm just going to move on to our next presentation. So we have Simon Barry, who is the lead for the National Respiratory Health Implementation Group in Wales. And Simon's going to be talking to us about the National Respiratory Digital Platform and its implementation. So over to you, Simon.
Thank you very much. Share. Can you see that?
We can, yeah. It's not in big presenter mode, but yeah, we can see the first slide.
Okay, fine. So thank you for inviting me. And what I'm going to talk about is the respiratory digital platform. So I'll basically, just a bit of a change in tack here, but what I'm going to do is take you through what we've done over the prior few years to try and achieve a national change in practice. And then I'm going to change tack halfway through to talk about how we utilize this to respond very quickly to COVID at a national level. So the mantra that we've developed is that if you want to change outcomes in healthcare, you need everyone knowing, learning and doing the things that matter. And there are always been pockets of excellence, universities, all sorts of groups that really know a great deal about expert issues and very great detail, but in reality, the whole population of healthcare professionals does not generally do the important things well. And the question is, how do you achieve that? And that's really what we've built, we feel. So what's been created here is a whole series of interventions, and those interventions are linked around creating alignment from policy to patient. So these include national guidelines. These include educational standards, so that we know, for example, that whenever anyone in primary care goes to see a patient with asthma or with COPD or with a tracheostomy or with whatever it is that's important, we know that they do the important things because they have to sign into a system and undergo a national standard or a competency, and they get a certificate when they've completed that. And we also focus very strongly on co-production. So we deal with creating patient-facing apps, which are aligned with the guidelines and the National Welsh standards. And we also have a quality improvement platform to help people achieve the correct goals. So the guidelines, first of all, nowhere else anywhere in the world has created this sort of guideline. There are plenty of guidelines about for all sorts of things, but no one has created guidelines which specifically detail what it is that you should be prescribing at particular time points for disease. They always generally say try this class of treatments or that class of treatments. And interestingly, between 2014 and 2019, we saved £9 million in prescribing in Wales, and over the same period of time, inhaler prescribing costs in Scotland doubled. So I've just this morning gone through the second iteration of our national guidelines for COPD and asthma, and these are heavily aligned to the green agenda, trying to reduce the usage and prescribing of high global warming impact inhalers, i.e. metered dose inhalers or puffers, which have a very adverse impact on the environment. So this is a sort of a very aligned national approach. That's the sort of guideline. It's very attractively put together with all the different steps. It's been passed by AWMSG, and as I say, it supports the decarbonisation agenda. And this is the sort of national Welsh standard. We've created these across the whole range of respiratory specialist areas, so pleural disease, non-invasive ventilation, asthma and COPD, all sorts of things, tracheostomy. And the idea is, therefore, we know where our workforce is, we know what it's trained to do, and we know that it's competent to do that. We've created a QI toolkit, which has been adopted as the official toolkit by the Royal College of Physicians for the National Asthma and COPD Audit. And what this means is that we know from the audits that at least a quarter of the patients on COPD registered in Wales, and that's nearly 20,000 patients, do not actually have spirometry consistent with a correct diagnosis. So this QI project can immediately identify those patients through digitally through Audit Plus, and those patients can be brought back, the spirometry redone, then recoded, and the correct diagnosis made, and thus improving the diagnostic yield in that GP. So we've got a whole range of different QI projects. It's all through the same integrated digital system. And lastly, patient apps. We have asthma for parents, we've got COPD, and we've got adult asthma, and we've also got a COVID recovery app that I'll mention later. So all of these things, and these apps are, like all of our innovations, they are bilingual, and they are created by healthcare professionals in Wales for Welsh patients. So let's go on to something completely different, as they said in Monty Python. So we'll go into COVID. So in March 2020, COVID hit in January and then February in Italy, and we knew it was coming in March. And it was like I describe it as a war zone. It was like a war zone, not just because people were dying, but because no one knew what was going on. It was total confusion. There was no guidelines. No one knew how to treat it. And there was people saying, do this, do that, flying all over the place. And suddenly it was quite apparent that we needed to create something that brought together what was the right thing to do and was highly adaptable. So as new evidence emerged, we could update all of the healthcare professionals so that they would know what it is that they need to do. So we created a digital implementation guideline, which was, as far as I'm aware, never been created anywhere else in the world before. I'll show you what happened. So this is part of a paper that's been submitted, but on graph A shows you these are the number of cases, COVID cases over time in the first wave, and these are the number of registrations, and these are the number of COVID deaths. And this is a cumulative total. So what you can see here is that there was a huge spike in cases, which correlated with a huge uptake in people signing into the system. So we had very quickly many thousands of healthcare professionals signed up, and the vast majority of consultants, senior decision makers who were involved in COVID care, were inside the system and were continually getting updates on how to treat patients. And that continues to be the case more than a year later on. we have updates coming all the time. And this is the format of the system. It does have a sort of a visual component to it, and there's a standard pathway here where you come in, you're assessed, you're triaged. All of our pathways only have 3 or 4 steps. They never have more than that. If you've got more than 3 or 4 steps, you've overcomplicated something which should be simple. And the decisions are made whether you admit, whether they go to ITU or not, and so on, and then you know, death or discharge essentially. And you can see there's QR codes which link into updates on all of the components thereof. And on the right is an algorithm about how to manage patients with oxygenation failure on the ward. So we did win an innovation award last year for this. So what we did as part of this is we thought, well, we've got to collect data on what's happening with patients in Wales with COVID. So as well as creating the guideline, we created a digital audit or data collection tool. And this, you can see part of that there. Just so you know, there's no PID, patient identifiable data collected. The postcode is put in there, but that just links to a multiple Welsh index of deprivation, and it's the index of deprivation that's stored, not the postcode. And there's a whole range of other things that are stored as well. And you can see for the first wave data, we did pretty well, with some health boards performing much better than other health boards. And this is how the data, this is in real time. We created a dashboard so every health board could see what was happening in their own health board on deaths and patients discharged. And this was a mortality for the first wave. So this will inform how Wales is seen. This will inform the report about how Wales did in COVID and you know what we managed to achieve. And we know from the first wave that the mortality was statistically significantly lower in Wales than the rest of the UK. So that is the mortality rate based on whether you went to ICU or the ward, fairly similar there, about 35%. And we wrote a paper about this, published in Thorax, and this really focused on nosocomial mortality. That's mortality for patients who caught COVID in hospital, which is significantly higher than patients who came in from the community with COVID, and not unexpected because those patients were older and frailer. And the second wave data is being collected now. That's from November to March, and will complete data collection at the end of this month. And you can see that Anaya and Bevan are smashing it. So the mortality data here for ICU shows that the ward mortality rate has gone down quite a lot, but ICU mortality has gone up. And, you know, partially this is the effect of treatments, new treatments that we have. We tend to manage patients in Wales on the ward rather than with various modalities that in other countries they manage in ITU. Okay, so just moving onwards here. So we created a COVID hospital guideline. We also created a primary care guideline. We created a COVID recovery app, a COVID recovery framework, and the database and audit, so that everything is being created through the same system, which cover all aspects of COVID. The primary care guideline, we've got 95% of practices, one or more GPs signed up, and it's a similar system, which is how is it that this is really focused on COVID recovery? So if you have a patient who's had COVID, who is it that you refer to hospital, and who is it you refer to a multidisciplinary team input? And so there's a system that GPs sign into, and there's various video-based guidelines from experts, be them respiratory physicians or cardiologists or neurologists, about how to assess a patient and who it is that they need to refer. And we got a very high pickup from primary care. So we've got good uptake from secondary care and good uptake from primary care. In December, just before Christmas, we launched the COVID recovery app, again, a bilingual app. it was created by multiple different professionals, physiologists, occupational therapists, psychologists from all across Wales. It was independently reviewed and had a very high rating. Anything over 60% is considered very good. We didn't ask for that, it just got assessed. So far we've had, last week we had 8,648 downloads. So ONS data suggests that 1 in 20 patients with COVID should have developed long COVID, i.e. symptoms more than 6 months. And we've got more people than that who've already downloaded the app in Wales. So we've got very good pickup. And my colleague Rhys Jeffries has worked closely with the long COVID group who have influenced the creation of this app. So this is a co-production app. So I think I've covered that, and I'm just going to summarize here now. So what we've done here is we've worked with a company who does digital innovation, predominantly around education, called the Institute for Clinical Science and Technology. And through that, we created a unique digital implementation system. And that system really has evolved through being developed for standard respiratory work and came into play acutely during COVID. And we're not aware of any other country that was able to react so quickly and so effectively at a national level to influence practice of prescribers and clinicians across the whole country. We believe that this shows Wales, leading the way in terms of digital innovation. And I suppose what I should say here is that a lot of the time people focused on innovations, but actually the important thing here is about implementation. And if you don't implement, you don't get outcomes. Okay, I'll stop there.
Thank you, Simon. And well, big piece of work, and and like you say, I think implementation is so important. It's great to do the testing, it's great to do the kind of the pilots, but it's about that implementation, and that is a big challenge, and usually comes with lots of questions from multiple kind of stakeholders. I'll ask a question first, so if you don't mind, but there's a lot of work there, and there's multiple components of that project as a whole, and there's some development of the workforce, there's some monitoring there. Are you at a point at the moment to understand the outcomes or the value that has provided to maybe preventing or worsening or trying to catch patients at a more kind of upstream point than they may have been in the past?
That's a good question. I mean, so in order to, we firmly believe, okay, I'll answer a slightly long answer to a question which could be answered with a yes or no. I mean, we believe that if you do the simple things in asthma care, for example, well, you'll get less deaths, but death is further downstream down the line. So, and probably there are other metrics to measure, which might be healthcare attendances at primary care or at accident emergency with asthma, for example. So, but in order to achieve that, you need to get the large proportion of those asthmatics in the country in the system. And so far, we have got a minority. We're not at that stage where we've got 300,000 people in Wales on those digital systems. Excuse me. However, what I will say is that there's been enormous implementation of this in children in Haldar, and there's a very active community pharmacist who's running around getting this into schools. And those young children with asthma, they have shown reduced GP attendances and reduced admissions to hospital. So in essence, the answer to your question is about implementation. If you implement these things, you get changes in outcome. And I'll go back to the COVID thing. We implemented that and we had lower mortality rates in Wales than the rest of the UK. And that never happens because Wales is more comorbid than most of the rest of the UK.
Okay, thank you for that. Does anyone have any questions for Simon? I think you've stunned them into silence, Simon. But you know that is an amazing kind of achievement, and I think that MediWales Innovation Award was well earned because like we said, implementation is not easy, but it is essential, and it is about bringing those people on that journey with you. And I think this is a good example of how to do that. And so I'm really keen that as the members kind of understand how they can learn a bit more about this, or how they can get involved, or where they can go to kind of to read a little bit more and get some more information. So if you're able to kind of share some links in the chat so people can kind of have a little look at that at their leisure. Sure. And it just means that we can, and if there's any way that if they want to learn any more in a bit more depth, if there's somewhere they can go to look for that as well. So that would be really helpful.
Of course. Okay.
Wonderful. Thank you, Simon. Thank you very much for your time.
All right.
Thank you. Okay, so we're going to move on to our next section, and part of our the Innovation Network moving to a more themed approach over the next kind of 12 months. What I was really keen to do is really involve a part of our team in Life Sciences Hub Wales, which is our kind of sector intelligence and our team, to really help us as a network kind of understand some of the kind of horizon scanning and what's on the horizon from a prevention point of view and an innovation point of view. So we've got a couple of members from the Life Sciences Hub Wales sector intelligence team who are going to firstly talk us through what the sector intelligence team is and kind of what are the services that we offer here in support of health and care across Wales with innovation. And then we've got a member of our team, Mike, who's going to be talking us through, and he's going to be doing this through the sessions as we go through the next couple of meetings, just some of the horizon scanning about what's really cool and quite innovative that's on the horizon for prevention. And yeah, he's going to have a bit of a host spot as we move through these meetings over the next 12 months. So I'm going to hand over to the team. So to Phil Barnes, who's our head of sector intelligence, and Sarah Taylor, who's a sector intelligence lead. So I'm going to hand over to them first, and then we're going to go to Mike. So over to you guys.
Thanks, Jonathan. Much appreciated. Sarah's going to drive the presentation for me because there are three of us. We thought it would be tricky to keep swapping screen sharing. So yeah, I'm Phil Barnes. I'm the head of the sector intelligence team at the Life Sciences Hub. Been in role for just over 3 months now. And as part of a new expanded sector intelligence offering at the Hub. Could I have the next slide, please, Sarah? So just to put things in context, I mean, in its broadest sense, the Hub is really here to be a connector and an integrator between the health and social care services, innovators, industrialists, research organisations and funders, with the aim of making a positive difference to health and social care in Wales. And this comes under an overarching vision of making Wales the place of choice for healthcare and wellbeing innovation. And Carrie Ann would be keen to point out that we already have a very strong life sciences sector in Wales. We do punch above our weight in that regard. But what we hope is that with the Hub's help, we can make that even stronger than it is currently. Next slide, please, Sarah. So in order to focus our efforts in this regard, we've identified 5 key impact areas, and we haven't plucked these out of the air. They've been selected in collaboration with health and social care partners and in conversations with industry and funding organisations and health boards. But we've made efforts to identify the kind of needs and market opportunities and an existing pipeline of interest from industrialists. And as you can see, these are a healthy aging, value-based healthcare, digital AI and robotics, precision medicine, and advanced therapeutic medicinal products. So that's our 5 priority impact areas. Next slide, please. So the sector intelligence team, it's part of the innovation and adoption group at the Hub, led by Dr. Griffiths, our innovation and adoption director. And the sector intelligence team consists of me as head of sector intel. We have 2 sector intelligence leads, Sarah Taylor, who you'll meet in a bit, Jordan Skoberg as well. And it should be both a healthcare market analyst and a healthcare market researcher, although the team is 1 short at the moment. Mike, who you'll hear from in a bit, is our healthcare market analyst, but we are recruiting at the moment for the 4th member of the team. Next slide, please. So a mixed bag of assistance that we can provide in this regard, and we come at this both from the sector pull angle, so health boards that are facing a challenge that they're looking for some help in meeting, but also from the technology push end, working with innovators who have a groundbreaking innovation that might be useful in the health and social care services. So in order to assist at both ends of this equation, we can conduct deep horizon scanning and innovation scouting, so we can help search for innovative products and techniques and methodologies in order to support specific healthcare challenges. And in order to do this, within the team, there's pretty broad sector expertise, but we also have access to some proprietary market intelligence assets that we can bring to bear on these problems. And we'll also work, as I said, from the other end of things, from the technology push. We'll work with innovation professionals, that's individuals, people already working within the healthcare service that have an innovative idea, and also industrial partners, in order to identify and triage some new technologies that have a strong potential to make a difference across Wales. Next slide, please. Next slide, please, Sarah. Thanks. We can also, in this regard, we can offer deep market analytics. So using both in-house expertise, our network of contacts, and as I said, the proprietary market intel assets that we have access to. So we can help with analysis of both the local Welsh, UK, and even international healthcare market dynamics. And we can help to identify strengths and gaps. And also, I mean, one of the most important things is emerging sector opportunities, new things that could make a real difference quickly and have the potential for adoption. Next slide, please. We can offer, in some regards, some quite specific bits of technical guidance, and this is partly from in-house expertise, but also if there's a need that goes beyond our own expertise, we can probably signpost to a network of specialist consultants that we know and have worked with in the past, in order to overcome some of the challenges that innovation requires. Adoption is not innovation and adoption is not an easy thing to do in health and social care. So, I mean, in terms of the specifics, one of these, and this is from the point of view of the innovators, is protection and prosecution of their intellectual property. If you've come up with a neat new innovation, very important that you're mindful of the intellectual property you've created, and you identify and protect that in a timely way and in a defensible way. We can provide some guidance on clinical regulatory pathways too, and also, if it goes beyond our expertise, we can signpost out to people with a deeper level of expertise than ourselves. And similarly, we can help with health economic modelling towards business cases. Next slide, please. As an arm's length body of Welsh Government, we are well placed to act as a neutral broker and convene diverse stakeholder groups to address clinical innovation challenges. A good upcoming example is the Welsh Early Detection and Diagnosis of Cancer Summit that we're organising, where we're going to bring together clinicians, funders, innovators, industrialists to look at the challenges that are being faced in early detection and diagnosis of cancer, with the aim of picking probably 2 key innovations that have the potential to be rolled out in a pan-Wales fashion and create business cases to support the adoption of these across Wales. And I think important in this regard is that we can speak the language of industry, we can speak the language of the clinicians and the patient groups, but also the funders, and obviously we have the ear of government as well. Next slide, please. And bringing all this together, one of the key bits of support we can offer is in business case production for the adoption of technologies. And we do this to the 5-case mode of business case production, which is the HM Treasury approved methodology as laid out in their green book. So hopefully that's given you a flavour of the kind of help we can offer. And as I said, if there are challenges that are beyond the sector intel team's in-house expertise, we probably know a friend who can help. I'll pass over at that point to my colleague Sarah, who will tell you some more about funding support.
Hi everyone. Thanks, Phil. I'm sorry, I'm having some troubles with moving the slides forward. Things are not moving when I'm clicking, so apologies for the delays. So as Phil mentioned, I'm Sarah Taylor, one of the sector intelligence leads at the Hub, and my focus is on encouraging funding for health and care innovation to come into Wales. Currently, the Hub's working on developing its funding services. We've got a fairly basic offering at the moment, and the focus really is on networking for collaborative bids. So bringing together stakeholders across industry, NHS, academia, local authorities, as Phil mentioned. So we can signpost potential applicants to the most appropriate funding schemes for them. We can offer support throughout the bid development process, including critiquing draft bids, helping with practice presentations and interviews, anything sort of throughout the bid development process we're happy to help with. We also have close connections with venture capital communities and can provide guidance on investment readiness, business planning and pitching for investment. As I say, though, all our funding services are currently under development, so we do hope to have an expanded offering in the next few months. John tasked me with looking at funding opportunities in prevention and population health, and as I'm sure everyone would imagine, that was a far-reaching, wide-ranging task. So what I've done with this slide is try to make sense of the landscape, really, in terms of separating things out into different stages of the innovation pathway. And try to highlight the areas where investment normally would happen. So at the lower technology readiness levels, you have your usual business investors, charity funders such as the Wellcome Trust, the Discovery Awards and UKRI funding schemes. So following completion then of basic research, funding is generally provided by Innovate UK. So schemes like the Innovate UK Biomedical Catalyst and Health and Care Research Wales, obviously, NIHR. And then at the adoption level, there really is a lack of funding providers. So the main one there would be the HTA awards from NIHR. So just to pull out some specific opportunities to try to give you some ideas or inspiration if you are looking for funding. The Wellcome Discovery Awards, they can provide early stage research funding, including population-based research. Health and Care Research Wales run a health research grant, which includes funding that can be used to develop or appraise new interventions. We also have opportunities to apply for the NIHR Public Health Research Programme, which can fund evaluation of non-NHS interventions. And as I mentioned previously, the Innovate UK MRC Biomedical Catalyst represents an opportunity for higher technology readiness level projects, which are business-led to develop in health and care. And finally, and probably most importantly, the Health Technology Assessment Awards, which can provide a high level funding once a technology is established as effective. So I just want to mention a couple of specific schemes that are relatively new, just to let people know that they're available. So Horizon Europe in the last 6 weeks or so have opened their latest funding schemes. Some of those in relation to prevention and population health are on this slide. I won't go through them individually, but I would encourage everyone to consider making an application to the schemes if you are able to, if you can meet the criteria. We won't have the opportunity long term to apply to these, and they represent really high value, high technology readiness level schemes with the potential to make real change in the healthcare system, and not just for Wales, but for the wider global community. There's also a new funding call, the Health Determinants Research Collaboration call from NIHR. The current call closes for expressions of interest on the 23rd of November. However, this is a pilot stage, so there may be opportunities in the future to apply for this type of funding. So this is a major new initiative which is designed to improve public health research infrastructure in local government. It will fund collaborative studies which link higher education institutions, local government and health providers. The idea is they wish to support the development of expertise, the generation of research evidence, and create a cycle of evidence-informed interventions, which will lead to better outcomes for the public. But as I say, it may be a bit short notice with that one, but maybe something to look to for the future. So hopefully a quick spin through of those opportunities has got some of you thinking about the opportunities that might be available to you. And I'll hand over to Mike now to talk about some of the new studies in prevention, and I really hope that my slide advancer works.
Thanks, Sarah. Hi everyone. I'm Mike Willson, the healthcare market researcher for the sector intelligence team. And to round things off, I've just been doing a bit of horizon scanning of novel research in population health and prevention, and we'll just be highlighting a number of recent studies that might spark your interest and just give an idea of what's going on out there, really. And it's been interesting being in on this session today, as a number of the studies that I found actually touch on a number of the themes that have already been discussed today. So so we'll start to go through these. Sarah, if I can have the next slide. Yeah, thank you. So this is just going to be quick fire. I'll provide citations and links in the chat if you are interested in finding out more. So this is the first one, called Project DARE, Improving Food Knowledge in Primary School Children. So this was research conducted by a group from Queen's University in Belfast, published in February of this year. So evidence suggests that the dietary intake of UK children is suboptimal. Poor diet quality in childhood has the potential not only to increase the risk of obesity and poor mental health in the short term, but can also track into adulthood, which may increase the risk of non-communicable disease in later life. So schools have been found to be sort of a very good environment for public health interventions, and as such, focus has shifted to the development of school food standards and the development of what's called a whole school food approach, which incorporates food-related education for children in addition to school food environment changes. And Project DARE was an intervention that aimed to improve children's health-related quality of life, well-being and food knowledge and dietary habits. This was via 2 multi-component interventions. So using this intervention, they found that improvements in childhood emotional and behavioural well-being, dietary intake, knowledge about food, cooking skills and willingness to try new foods was associated with their Nourish whole school food environment intervention. So Nourish was an intervention aiming to alter the whole school food environment, provide food-related experience and expose school pupils to locally produced foods. So that was the first one. We can go to the next slide, please, Sarah. So the second one is to do with e-health intervention and medical adherence. Just posting this one. So this was a study conducted by a research group in the Netherlands, published in January of this year, looking into the effects of e-health intervention on improving medication adherence in adults using long-term medication. So the benefits of taking long-term medication will only be reached if patients actually adhere to their medication regime. And according to the study, up to 50% of all patients with long-term medication are non-adherent, which would lead to suboptimal treatment outcomes. Here, in this study, e-health is offered as a possible solution. So e-health here is basically defined as the use of information and communication technology in healthcare. So it's sort of quite broadly, they're sort of referring to e-health. So they're saying that this can provide an opportunity to offer accessible, interactive, timely and feasible medication adherence interventions that require minimal effort from healthcare providers whose time and resources are limited. So this study found that a majority of interactive e-health interventions are effective on improving adherence to long-term medication. And whilst most interactive e-health interventions were multifaceted, even simple technologies such as SMS text messaging and telephone calls can be effective in promoting medication adherence in a wide variety of patient populations. So that was the second one. We can go to the next slide. Thank you. So the third one is to do with a virtual reality exergame to engage adolescents in physical activity. So this is referring to exergaming as sort of games requiring body movement. So essentially it's the incorporation of exercise into video gaming. This was conducted by a research group at University College London, published again in February of this year. So with this one, it was looking at physical activity in adolescence. So early adolescence is critical to developmental. Early adolescence is a critical development stage for physical activity promotion, but there is a substantial age-related decline in activity levels from childhood into adolescence. And VR, or virtual reality exergaming, has been seen as a promising intervention strategy to engage adolescents in physical activity. So this was an intervention looking into this one. We can have the next slide, please. Study number 4 is an evidence-based walking program in Oregon communities called Step It Up Survivors. So this one was conducted by a research group in Oregon Health and Science University in the United States. This was published in December of last year, and this was about the establishment of walking groups to promote physical activity in cancer survivors. So physical activity can help mitigate the long-term symptoms and side effects of cancer and its treatment, but most cancer survivors are not active enough to achieve this benefits. A potential solution lies in group-based exercise. So group exercise has resulted in greater improvements in primary outcomes compared with unsupervised or home-based interventions among cancer survivors. And an evidence-based strategy to promote physical activity among adults is a community-based walking program. So this was an investigation looking into how these sort of walking groups could be set up in a way that's that could be achieved sort of in the real world. And if we can go to the next one, please, Sarah. And this final one is on extreme weather and climate change, population health and health system implications. So with the UN climate change conference happening at the moment, this one seems quite relevant. So this one was contributed to by various authors across the United States and Canada, and this was published in the Annual Review of Public Health in January of this year. And this is a review of the system-wide adaptation that's required to keep health systems resilient to a rise in extreme weather events. So extreme weather events and events influenced by climate change can continue to cause significant human morbidity and mortality and adversely affect mental health and well-being. And although adverse health impacts from extreme events have declined over the past few decades, climate change and the movement of people more into harm's way could alter this trend. So this is an investigation looking into how health systems could potentially adapt to become more resilient to the effects of climate change. So if we can move to the next slide, please, Sarah. So that's just a sort of a list of those citations. If you are interested in finding out more about any of those particular studies, yeah, you can have a look at those links and the links that I posted in the chat. Next slide, please. So that was it from us. I think this is the sort of just a contact list. So these are sort of contact and social media details for the hub as a whole, but you can also reach us directly by using the email addresses at the bottom. So there's email addresses for Phil, Sarah, and myself. So yes, I think that was it from me. Thank you very much.
Cheers, Mike, and thanks, Phil, and thanks, Sarah, and I hope that's kind of give everyone a bit of an overview of what is a developing service and a team within Life Sciences Hub Wales. But I think, you know, we're really keen that Sarah and the team are able to support the sector and the ecosystem. And Sarah did a great job of pulling together all those funding opportunities. So I'm impressed. Fantastic, well done. But yeah, and thank you, Mike, for looking into those. And hopefully Mike's going to have a bit of a spot now every time we do an innovation meeting, and just to kind of challenge us as well to think a little bit differently and think outside of Wales and see what's on the horizon, so we can really kind of push ourselves to be a bit more, you know, to really drive that innovative mindset within the network and the membership. So thank you, guys, and thank you very much. And I think everyone's going to put their details in the chat. So we've come to the end of today's meeting, and I hope everyone's enjoyed. And like I said, this is the first of our series of themed meetings, and what it allows us to do is really focus on each meeting about getting the right speakers in and getting the right examples in, but it also helps you as members be able to come to these meetings really knowing what to expect, but it also helps us, or helps you as members, to be able to contribute to these meetings, and that's kind of moves me on to the next point, which is the next 3 meetings are going to be themed. So the next one is going to be, which is in January, 1st of February, beginning of February, which is going to be about access and decision making. The one in spring is going to be about diagnosis and assessment, and then the last one in summer is going to be about management. And those are going to be, all around the theme of innovation. And we really want to hear from you about where you'd like to contribute to those meetings. So if you've got projects or solutions that really kind of fit within those areas, and we've tried to keep them as open as possible so they don't lend themselves more specifically to health or more specifically to care. So please get in touch now if any, and those themes will have been in emails that we've sent you recently. So if there's any that you think, oh, do you know what, we've got a project or we've got a solution in mind that really kind of fits within that kind of theme, please get in touch and we can start to talk about what that might look like, or having a presentation slot or sharing some information. We did have a number of people who wanted to present today, but the agenda just got packed like within a couple of weeks. So thank you to everyone who did kind of reach out and say they wanted to present. But what we've done in that case is we've asked people to share some information with us about their projects that they wanted to present on. So we're going to send that to you in our follow-up email following this meeting so that you can have access to those resources. It was just to kind of say thank you to everyone, you know, thanks for joining. And we know there's a lot of, you know, there are a lot of events on at the moment, and I know that we're competing with a number of those. So it's just great to see some familiar faces and kind of really get the discussion moving, you know, moving forward around this topic. And prevention is massively important. I think, you know, if we look at a population health perspective, it's such a key component of that. But I think we can all agree over the past 18 months, it's really been kind of brought to the kind of the front of how important it is as we move forward with managing health and care. I just wanted to say as well, as we are on the theme of prevention, so the Bangor ILAs, the Intensive Learning Academy for Prevention, is currently taking applications to go on to that course, and it's got, you know, it looks like a fantastic course. So we're going to send the information for how to get involved there and how to get in touch with them in the follow-up email as well. And just to say, so it's the 1st of February, so you're going to get a link to, so what we're going to do is I'm going to give you a link in the follow-up email to the next meeting so you can get it in your diary, so you can put it in the diary, so you don't have to worry about remembering to register. So it's there, you can't forget about it, and you know, it's ready to go when it comes to February in the new year. And just to remind everyone so some of you will be getting those emails about the Simply Do platform, and you know, we really want people to engage with it and try it and just kind of come with us on this journey as we try to kind of make that an opportunity to improve that kind of networking and discussion and kind of sharing aspect of the network. I'm trying to think if I've forgotten anything, but I don't think I have. But so I'll close today's meeting just by saying thank you to all of our presenters, and I think, as always, insightful and inspiring, and some really great work taking place. And I think lots of opportunities where other members can get involved, which is always fantastic, and spread the word and kind of contribute to the wider kind of impact of those projects. Nice to see everyone, and yeah, we'll finish a little bit early, and hopefully we'll see you in the new year, and have a good Christmas, and yeah, we'll catch you in 2022.